Okay. So before I just kind of open it up, let's just do real quick introductions. If you want to just state your name and where you're affiliated. So everyone, I believe, making sure. Okay, I see everybody here. So Mike McKee, professor here at Department of Family Medicine. I'm gonna go in the order of my screen here. So Heidi, you're next.
Hi, everybody. I'm Heidi Joshi. I'm one of the assistant professors in the Department of Family Medicine here at University of Michigan, and I work with predominantly with the residents, and I'm our behavioral health educator.
Great. John.
Hi, everyone. I'm Don Michael. I'm Disability Program Coordinator, and I work with Dr. McKee here in the Department of Family Medicine.
Wonderful. Dr. Johnson-Hooper, I'm going to skip you since I'm going to give you an introduction. So, Tess,
My name is Tessa Kirchner. I'm a current PhD student in the School of Nursing. I'm also a past MDisability intern.
wonderful. Liz,
Hi, I'm Liz Katz. I'm the science communicator for the Department of Family Medicine, and I also work closely with MDisability to promote activities with the program.
great. Philip,
Hi, I'm Philip Zazov. I'm retired, loving it, former faculty and chair of family medicine.
Talene,
I am Talene Latimer, and I am a postdoc here at CDHW, Center for Disability Health and Wellness.
great. Megan, good to see you.
I'm Megan Pesh, Developmental Behavioral Pediatrics.
Great. Jane, hello.
Hi, I haven't been able to make it to a meeting in a while, so I'm happy to be here. I'm one of the family medicine faculty. I also do palliative care. It's lovely to see everybody.
And just a quick shout out, Jane, thank you so much for your presentation. It really fostered a lot of interest. I know Tetra reached out. So Jane actually gave a wonderful talk about palliative care for, especially for individuals with intellectual and developmental disabilities. I'm sorry, I'm blanking on the exact group, but I just want to give a shout out to that. Thank you.
You're welcome. It was a great, I'm just happy that it's been able to be helpful. Thanks.
Wonderful. Yeah, I want to make sure I'm pronouncing this right. Is it Cabero?
Hello, good morning.
Do you want to briefly state your name and your affiliation?
Yeah, I'm a student from Ireland. We are a team from Peru. Mark invited us to participating about this meeting, and I'm glad to be here.
Welcome. Well, that's great. Okay.
Thank you.
And then Logan.
Hi, I'm Logan Roberts. I'm a research area specialist here in the Department of Family Medicine.
Okay. Jody.
I am Jody Cushman. I'm a research coordinator with the Department of Physical Medicine and Rehabilitation.
Great. Samia.
Hello, my name is Samya. I use my name or any pronouns. South Asian person with headphones, dark hair, and glasses. I'm a research specialist with Dr. O in disability services and a PhD student studying health professions education.
Great. Monica.
Hey everyone, my name is Monica. I was a post-bac at UMich a couple of years ago, but am looking to get back involved with the UMich disability community as I plan to apply to graduate school and hopefully the MDisability internship if one of those applications open up this summer for the summer.
Great. Well, thank you everybody for attending. So I just want to give a brief announcement before we move on to, and we'll invite Dr. Johnson-Hooper to kind of share some of the wonderful work she's doing. So in terms of the provost, just a reminder for some of you, we were able to get one of the provost awards, and this is for the Disability Scholarship Initiative Project. We are particularly interested in learning more about the workplace experiences for staff, faculty, and certain trainees at Michigan Medicine. These are individuals with disabilities, and we're very interested in learning about what might be barriers, what works, what does not work. And this will be the first time this has been done at Michigan Medicine. This is really going to potentially, most likely, will spin off 3 additional interventions. So there will be additional resources shared as sort of like a clearinghouse on how to make things more inclusive, accessible, so that they can thrive. And then the second one, we will be doing a series of workshops at different, whether it's schools, departments, and we'll be getting that set up for Michigan Medicine folks. And then there will be a mentor mentee sort of matchmaking service to provide a little bit of navigation and a little bit more assistance as people navigate. So more to come. The reason why I'm making this announcement, we have completed our first part, which is the survey, and we will be reaching out to many of you as a sort of a disability advocate champion. If you can further spread it across your departments or wherever you're at. This is only for Michigan Medicine, so we'll be reaching out to some of you. So if you see this email, that's what we're trying to do. Dawn, anything else I did not mention? Anything to add before we move on?
No, just to say that we will be sending out the cadence for the 2026 monthly meetings in the next few weeks, and also the internship applications will be opening as well, or the call for submitting those by the end of November, beginning of December. Thank you.
Wonderful. And yeah, if you have any ideas, Megan, I will be reaching out. I apologize, I overlooked your email until recently, so I'll be reaching out. Love to have you be one of our guest presenters coming. So I am delighted to move forward to our next phase of this meeting. So Dr. Johnson-Hooper has graciously agreed to show up and share some of the work that she's doing. And so I want to just provide a little bit of information, and then we'll move on, allow her to share some slides. So Dr. Johnson-Hooper is a medical director at the Henry Ford Health Generational Resilience, Opportunity, and Wellness Center for Autism and Intellectual Developmental Disabilities. And she's going to share some of her work and discuss some of the healthcare access barriers, especially for individuals with intellectual and developmental disabilities. She is particularly interested in their lifespan. And I know she was trained as a pediatrician, but she has now moved over to family medicine, and so now has like really incorporated not only the children, the transitional challenges, but also adults with IDD. And she's working at Henry Ford Health, and really has we've already had a brief chat earlier and doing some really amazing stuff there. And then in terms of her affiliation with Henry Ford, this has been going on for over 25 years. And as I mentioned, she's the director for this center. And her clinical responsibilities, she provides pediatric primary care for children with autism and intellectual developmental disabilities, as well as participating in, which really sounds like an amazing multidisciplinary autism diagnostic team. And she has also appointments at the clinical assistant professor at Wayne State University School of Medicine, also the clinical assistant professor at Michigan State University College of Human Medicine. And she also serves as a teacher and one of the wonderful mentors at part of the Michigan Lend program. So we're excited to have her join. So with that, I'm going to turn it over to Dr. Johnson-Hooper. Are you able to share your slides?
I am going to share. Thank you for the intro. Tell me when you can see.
Okay.
How's that?
Is currently loading up. Yeah, we can see it now. Okay.
Okay, excellent. Let me do this. I am horrible with. There we go. So you guys see it fine? Okay, excellent. Thank you for the introduction. I'm excited to be here. I attended University of Michigan for undergrad. Once a Wolverine, always a Wolverine. So I love it. And I'm really honored that you guys are including me in this wonderful talk. So during this time together, I thought what I do is I share my motto, which guides my professional life. So what you'll see is why this motto is applicable for what I do. I don't know if you guys even remember this movie Robots, but I'm a pediatrician and I love cartoons. And this is one of my favorite cartoons and one of my favorite sayings: see a need, fill a need. And I realized in me sharing my screen, I don't see you guys. So this is informal. You can stop me if there's any questions, any issues, just stop me. I can't see you, so just jump in. Okay. So really, by me sharing this, my favorite model, you'll get a sense of really how see a need, fill a need really informs the work that I have done, the work that I am doing. So as you heard, I am a pediatrician. I did, after my residency, I did 1 year of developmental behavioral pediatrics fellowship at Boston Children's Hospital, moved back to Michigan because of my husband's job. And at the time I thought, oh, I would just pick up the fellowship, but I'm showing my age. There wasn't one in the area at the time that I moved back, and joined Henry Ford in a multidisciplinary spasticity clinic, and did more spasticity, spina bifida, multiple multidisciplinary type of care before I moved to just doing primary care for this population. Then in 2008, co-founded the Center for Autism and Developmental Disabilities in the Department of Pediatrics. And since that time was one of the multidisciplinary team members. But because of the needs that the expanding needs, the healthcare barriers that I observed really was the impetus for me to do something different, to try to fill a need. So that's where I am. I love to always use a story, realistic story, to kind of illustrate my need or illustrate my point. So I'm going to start by telling you about a story that just happened a couple months ago, 2 months to be exact. One of my colleagues who is in Ohio, who runs an adult autism program, was telling me about a patient that he just received there. The patient was from Detroit, actually, but he was going to Ohio for primary care. His parents really struggled to find a primary care physician that could meet his needs, and he asked me to help out. So I reached out to one of my family medicine colleagues and asked, would she mind seeing this patient? She said most certainly she would see him, but she had like some stipulations. Specifically, she said she'd see this patient in her primary care if, we could have a specified date and time, a time in which I would be in clinic during that time and could give her any support that she possibly would need. And she asked for the medical records before seeing the patient. So nothing huge were her ask. So the medical assistant reached out to the family. For what I'm not sure why, but never made actual connection. The family called back and got the call center. So as you can imagine, the patient was scheduled, but not at the specified date or time that we were expecting this patient. On this particular day, they showed up. The provider nor I even knew that the patient was coming in that day. The patient came in accompanied by his parents. The parents had very specific concerns. They were concerned about this young man's increasingly worsening self-injurious behavior, insomnia, and psychiatric care. He actually hadn't had psychiatric care in a few years while having a history of multiple medications. So when this particular day, the primary care provider was running late, as we typically are running late, but she noted that, she walked in late with no history. And immediately the parents were really frustrated when they quickly realized that their expectations would not be met at that moment. So the visit ended really without much being accomplished. The family medicine doc did promise to follow up after she obtained some guidance, and she and I kind of debriefed and talked about the experience, like the medical workup for self-injurious behavior or some behavioral health intervention that would have been applicable. We just had a really long conversation, but more importantly, what I'm sharing is I asked her really her feelings about that experience, and that's really what I'm sharing with you today. Essentially, what she said was that she felt hopeless in that moment. She said she never wanted to feel like that again. The experience sits with me every time I see a new patient on my schedule. When she said that, my heart sunk because I thought, oh my God, did I just create PTSD in this woman? Because she really was mortified about the experience. She said I had nothing to give them other than a space to sit for 45 minutes. And there was no heads up, no background history, inappropriate scheduling, and the parents' unrealistic expectation all led to a perfect storm. So, I mean, like each of you obviously share the desire to increase your own knowledge and competency in this space. But I think this example really illustrates a need beyond just having better knowledge and competency for the care of those with IDD, but it demonstrates the need for better scheduling or workflow, better supports and resources that clinicians must have. So I shared that because it just happened and illustrated my point specifically. But this slide, and I'll tell you guys, I talk fast, so stop me if I'm talking too fast. But this is a slide that I like because I adopted this from a paper. It's a 2022 paper by Shacker et al. And I adapted it, and I've been adding to this list. This is a list of healthcare barriers encountered by those with autism throughout the lifespan. And I really love it as we're talking about what the needs are. When I came across this paper, I'm like, yes, these are the needs. These are barriers experienced by folks with autism. And quite honestly, they're barriers that really can be generalized to other diagnoses. But specific to autism, in this paper, they broke up the barriers across the lifespan, starting with, childhood, especially in our state, limited expertise and capacity for autism screening. Lack of awareness of the referral process is so pronounced. Limited access to autism diagnostic centers. I'm sure you're aware of the years that families wait to get into a diagnostic center, and really limited knowledge of healthcare pathways. Suboptimal physician awareness, and really that holistic approach for families. The stigma and healthcare hesitancy, it goes across the lifespan, quite honestly, as does the suboptimal physician awareness. We certainly see that compounding, getting worse as one ages into the adulthood, but it's seen across the lifespan. Really, I'm not going to call out everything on the adolescent side. What I'll call out specifically, which is most impactful and near to my heart, is really the healthcare transition. Really, there being no healthcare transition process for populations with autism. And in some of the literature, it does demonstrate among those with IDD, those with autism are least likely to receive any healthcare transition planning preparation as one moves into an adult approach to healthcare. And the reason I call that out is we know that this is a time where gaps in care widen and ultimately health outcomes are worsened. So this is a time where there's a lot of need. And as we age, we definitely see significant barriers or gaps. Specifically in our state, we have no adult diagnostic centers for those seeking evaluation. For those that are independent and seeking care, definitely communication, sensory issues are huge barriers to accessing care, regardless if it's primary or specialty or even emergent care. And on the adults really exhibiting limited knowledge of very complex health systems. You guys are at Michigan, it can be quite complex to navigate healthcare. And then, as my example of my colleagues, clinical workflows, appointment barriers are significant. And we talked about clinician and workforce knowledge. So this is really kind of an overarching barrier. And I would ask, and every time I show this slide to folks, I ask folks to, if there is something that is missing, please call that out so I can add it, because I really do compile, the list, because I want to see the need, and then I want to shift to fill the need. And so these are the needs as we see it. And this next slide just really illustrates for the population of those with autism, the disproportionate amount of both physical and behavioral health co-occurring diagnoses experienced in this population. And the reason I even put this slide up there, now in family medicine, at Henry Ford generally, we have a clinically integrated network that has specific health outcomes that, the health system is looking at, much of which on the adult side are those, adult chronic health disorders like diabetes, hypertension, obesity. And I always wonder, in our approach to mitigating these chronic health diseases, how often are we stopping and saying, how might we modify or adjust our approach based on the patient's diagnosis of IDD or autism, especially since disproportionately they will have these co-occurring diagnoses. So this slide and the next is just demonstrating what those prevalence of these chronic health diseases. This is Michigan data specifically looking at, depression and behavioral health, but then chronic health issues like obesity and heart disease, looking at those with versus without disability generally. So I kind of just wanted to highlight the need as I have seen it through my eyes, how I, in the years I've been practicing and just identifying these barriers or gaps in care. This really was the impetus for me moving into the work that I'm doing now. In January, just this year, January 2025, after 25 years in the Department of Pediatrics, I moved departments, and I'm now the only pediatrician in the Department of Family Medicine. So I joined family medicine. I left the work that I did in the program I started in PEDS, the Center for Autism and Developmental Disabilities, and I moved to really launch a new, broader program. The idea was that we would launch a program in family medicine to address the needs of patients and families across the lifespan. That was truly the purpose. And so from there, we launched the Generational Resilience Opportunity and Wellness Center for Autism and Intellectual and Developmental Disabilities. And I know the name is a mouthful. Many people have given me that feedback. Like, it's so much. But I want to tell you, our name is intentional. Our name really embodies kind of a holistic approach supporting these patients and their families. Component of the name really holds significant meaning, and I'll read this to you because it really took a while for us to come up with this name, but it's meaningful. The first part, generational, it highlights our commitment to creating a lasting impact across families and communities, and it signifies the goal of fostering a legacy of health, not just for the individual, but we really want to focus on future generations. Then there's resilience, and it reflects the strength and the adaptability of individuals and families facing the challenges associated with autism and IDD. We foster foster self-advocacy while nurturing the ability to overcome obstacles, encouraging both individuals and families to thrive despite difficulties. Opportunity underscores our dedication to providing access to healthcare, resources and support that open doors for our patients and their families. By creating opportunities, we will empower individuals and families to achieve their potential. Then last but not least is wellness, which signifies a comprehensive approach to health encompassing physical, mental, and emotional well-being. We really do aim to promote overall quality of life for individuals and families, ensuring that they have access to the necessary tools for holistic health. So we call our program GROW. It's just so much easier, but I just wanted you to know there is method behind the madness of our name. So specifically with GROW, our mission is to provide access to integrated, comprehensive family-centered healthcare, serving individuals and families with disabilities across the lifespan, and we're really leaning into that. So GROW, we leverage 5 pillars to address our mission. The first pillar is lifespan diagnostic care, integrated healthcare, therapy, education, and research and quality improvement. We're leveraging these 5 pillars to achieve our vision: empowered individuals and families living with IDD, thriving and reaching their fullest potential with optimal health and well-being. So if you remember the slide with the need, the barrier, what we attempted to do was to look at these opportunities and to develop a model of care across these 5 pillars, really to address each and every one of those barriers that I highlighted. Specifically, this is our roadmap, if you will. This is the work that we hope to do across our 5 pillars. Each of our 5 pillars has a lead, a physician champion or lead, and that lead convenes monthly work groups, really to work through the objectives, to implement the work to achieve our objectives. So we have an education lead. And around education, what we hope to achieve is just improve healthcare workforce IDD knowledge, skills, and self-perceived competency. Our education lead is working on creating a centralized education database in IDD. And really what was foundational is we had a master's public health student work with us during her internship and began to create kind of an IDD compendium, if you will, of training and educational resources. We wanted to look what is out there, what is existing. And that was what we were kind of building from, scaffolding from that. We definitely in our program want to expand upon our medical school IDD electives. We currently have 2, one with Wayne State and the second with Michigan State University for their medical students to rotate through our program. We putting together lectures to push out throughout the health system that we can provide grand round lectures. We hope to launch an inaugural statewide IDD symposium in the years to come. And then on education is we are working in collaboration with the Autism Alliance of Michigan and the Michigan Developmental Disabilities Institute to create a healthcare workforce IDD kind of e-learning modules that we can push out throughout our health system. On the therapy side, that is head by Dr. Emily LaRose. And Dr. LaRose is charged with focusing on establishing really a comprehensive lifespan therapy program. It's interesting right now, if you are 25 and have IDD and a developmental language disorder, there's only one speech and language pathologist that has the skills and the knowledge to address these issues within this population. And so that clearly is just a shame. And so our goal is to look at all the therapy programs and look and see how we can expand it out to meet the needs of all of our patients within our very large and growing expansive health system. We want to establish a first for Henry Ford, and that's a BCBA consultation program, meeting the needs, not just of the emergency room, but ambulatory services, inpatient services to support patients who may have behaviors that interfere with them receiving medical care. We are creating a resource kit, IDD specific resource kits that we can then generalize, disseminate out through our health system, expanding the role of our social workers. And then what we want to do is look, and through that compendium that we looked at, identified where might there be opportunities to create therapy certifications. So those are Dr. LaRose's therapy objectives. Research is led by Dr. Melissa May. She's an implementation scientist and one of our team members in our multidisciplinary diagnostic program, and she has lofty objectives. She's working very diligently to establish a funding and sustainability of our research model. She is looking at ways to increase our research output and dissemination, and really working to build capacity. And this building of capacity is really working with other departments, multidisciplinary collaboration to really push the research forward. And we're looking at ways of developing advisory boards with patients and caregivers to making sure our research goals are co-created. She's establishing a tracking process across institutions and community engagement to track the work we're doing in research. On the diagnostic side, I am heading up both the diagnostic and our healthcare pillars. Specifically on the diagnostic side, our goal is to establish a lifespan diagnostic process. We have our pediatric process already established, and we launched that earlier this year. Our hope is by the spring of 2026, we will have launched our adult diagnostic virtual multidisciplinary practice. And so we'll be the first in the state to have that lifespan diagnostic program. It is a multidisciplinary program pulling from services from behavioral health, psychiatry, neuropsychology, speech pathology is involved, family medicine. Me as a pediatrician, I'm involved. We are collaborating with genetics for genetic evaluation. So it's definitely a multidisciplinary approach. We have launched a database because many of the folks that are involved in our program often have queries or clinical or even research questions, and our database is definitely helpful to support that work. A couple of years ago, I worked with Press Ganey to create patient engagement surveys for our diagnostic and ABA services, really in order to leverage patient engagement surveys as a tool for constant quality improvement efforts. And so we've launched that across the lifespan. We do not have a brick and mortar at this juncture, and we are working diligently to find one. And so our hope is to be able to have a hybrid diagnostic program. As we identify, virtual diagnostic may not be appropriate for all patients. And so we want to make sure we are there to meet the needs of all of our patients. And then we're constantly working to expand our autism diagnostic disciplines. On the healthcare piece, this is work that is particularly exciting for me and the reason for my move to family medicine. I'm now at Harbortown Medical Center, which is in Detroit. It's a family medicine residency medical center. And so one of our goals there is to establish a Michigan Developmental Disabilities Most Valuable Provider, MVP certification at this site. So currently, the workforce there is undergoing education around IDD. We've had environmental and sensory evaluations of our site, making those modifications to meet the express needs of our patients, and working on ways of ongoing identification of disability so that we can achieve this certification come the spring. We are definitely constantly refining our ongoing IDD training for our workforce. And I say the word workforce because we make sure not just physicians and the residents undergo this training, but as do our medical assistants, our nurses, CSRs, security at Harbortown. There's a radiology tech. So if you work there and you interface with patients, we want to make sure we have ongoing education and training to remove that as a barrier for healthcare. We are working, and I trust you will empathize with Epic, but really working to integrate tools into Epic so that we can disseminate a standard of care throughout our health system by leveraging technology. Specifically around healthcare transition, I have worked with Got Transition in their learning collaborative since 2012 and have been charged with implementing the 6 core elements within our health system. And I'm continuing that work by focusing now specifically on this patient population to create a very standardized, structured healthcare transition process for this population. And then we want to develop really novel models of care, like an integrated primary care model with different disciplines, and looking at that and hopefully using that as a basis to engage our payers to develop, an IDD specific value-based care model. That's an ultimate goal, and we're manualizing the process. So this is kind of our roadmap to address the needs, that one PowerPoint slide that depicted the needs across the lifespan. And this is our answer to it, if you will. Okay. Let's see. Oh, just the next couple of slides really is kind of things that we're doing concurrently to those objectives. I just always highlight our book club. We established a wonderful book club. We meet quarterly, and it's a book club that we read books on disability. And we have themes that we're addressing. And as a matter of fact, tonight is a book club night. We're reading a memoir tonight, or we're discussing two memoirs, as a matter of fact. But I love it because it's a great way for the GROW team and the health system, people who are not involved in GROW, but getting together and sharing their perspective and having thoughtful discussion around disability. This slide reminds me the work that we're doing in healthcare. We're very fortunate to have received a wonderful grant from the Stephen Grand Foundation in collaboration partnership with the Autism Alliance of Michigan to set up our primary care practice for populations with IDD at Harbortown. Stephen Grand has donated funds specifically for this purpose, and this is what is really propelling our work forward. So I always want to shout out to Stephen Grand Foundation. The last slide is another wonderful thing that we're doing that we're excited about. As you may be aware, folks with autism oftentimes have co-occurring feeding difficulties at the extreme, like ARFID or avoidant restrictive food intake disorder, and oftentimes have health outcomes of obesity or diabetes disproportionate, as I demonstrated on the other slide, around their lifestyle. And so one of our speech pathologists, who's an avid gardener, in our conversations of what other novel ways can we engage the community, support our families, came up with this idea. And in January, we're going to launch our Grow Garden in the Henry Ford West Bloomfield greenhouse. It's a beautiful greenhouse, but we have a lot of space where we're going to bring in our patients and their families to garden, to teach about vegetables, healthy nutrition, work around those sensory issues that may impact kids from expanding their dietary repertoire. We have a postdoc kinesiologist that has put together movement activities, working on fine motor skills, and then the chef there at West Bloomfield is going to do cooking classes for the kiddos and the families, and really support parents in coming up with creative ways of integrating fruits and vegetables into their everyday diet. So, I mean, we are definitely, our research pillar are looking at very specific outcomes to follow, whether it be like a health outcome, but also we're looking at family quality of life. How can we impact that through our Grow Garden? So I spoke fast. I wanted to leave time to chat because I trust there's a lot of collaboration that we can explore, and our interest aligns greatly. And so I just wanted to leave you, and I'll make sure you have these slides with ways of engaging or getting in touch with us should you have patients or families in our area looking for primary care or looking for an option for a virtual multidisciplinary diagnostic care. So I think that may be it for me. Let me see if I can stop sharing.
Thank you so much. This is really incredible what you guys have been able to do. In terms of what I would like to do, if you can put your link for your center, if you want to put it in the chat, I think a lot of people would love to just open it, save it, and bookmark it. I do have a question for you. So given you work with a number of different folks in family medicine and also other specialties in primary care, what are some of your tips or strategies to try to improve the quality of care for people with IDD in primary care? So how do you get them to buy in? What are some tools, strategies to kind of get them to hopefully move the needle a bit? What do you do with your folks?
So I just wanted to make sure I heard the question. What are the strategies, tools that we've used to engage? And then I'm sorry, I missed what you were saying.
Yeah, sorry, it was kind of a long-winded question. So I was trying to get at how to get primary care providers to kind of like buy in, to understand the importance of caring for these individuals. I know a lot of pushback from them is like, I don't have enough training, or it takes too much time. What are your sort of tips or kind of tools or even pearls of wisdom that you can maybe impart for all of us to hopefully get people to do more?
Yeah, I truly think that as physicians or healthcare workers, people go into this work not because, they want to make tons and tons of money, clearly because there is a passion there to help. And one thing that I have found to be beneficial, whether I'm talking to physicians, nursing, and we can't forget our administrators, our policy makers, right? It's to meet them where they are. And while this work may be a passion for me, just like the example that I gave with this young, and she was a young family medicine doctor. And the reason I, sat and talked to her is I really wanted to get a sense of what she saw as those barriers so that when I am working to implement change, it really is addressing her pain points. And quite honestly, at least what most primary care doctors have told me as the pain point is, like you said, the lack of education and knowledge. Another pain point that I think is most significant is the time that patients with IDD take when we know as primary care providers, we are incentivized by our productivity. And these are not patients that they will certainly negatively impact your productivity. And then even outside of the clinic space, it's all the documentation, it's the lack of knowledge of resources. And that's just frustrating, quite honestly. I would not want to see a patient if I have no idea what to do with them. So really what I've done to try to engage providers, I will say, like if someone said to me, it's just too much in documentation. So I'm like, if I were to help with documentation, if I streamlined it, if I made it easier, if I supported you in this effort, might you want or be able to see these patients? And so typically the answer is yes, like if you took away this barrier. And so when I think of workflow, what's really difficult in a large integrated health system like Michigan or Henry Ford, you can't just make change at the individual or clinic level, right? And that's what takes so long and is so maddening. So what I ultimately always do is I create like the optimal space, and then I try to get the decision leaders in the room. And I try to figure out what's important to them. So for instance, what is important to someone who is on the clinically integrated network where they want to close those health disparities, improve health outcomes? I've asked the question, how many of our patients with IDD also have hypertension or obesity? And how are we addressing it? And I've had folks say, well, gosh, I don't know. And so one of the things when I keep getting these I don't knows, for me, it's again, see a need, fill a need. And so one of the things I've done, Dr. May, Dr. Allen, and one of the researchers at Michigan State, Dr. Amy Drahota, we have a research project that we're funded to identify the prevalence of patients at Henry Ford with IDD. So we're actively working on this. And so our goal is, once we identify the population, we're going to stratify them across all of the major health outcomes that the health system is actually engaged with improving, to be able to demonstrate to the powers that be that, geez, this is a number of patients that we care for and look at their health outcomes as compared to those without IDD. Hopefully we then, because we know that is their priority, will at least get their attention to say, all right, we now have some suggestions of how to close those gaps. And so, long-winded way of saying, I think I always try to figure out the folks that I'm talking to, what's important to them. What is their barrier? And then I try to address that barrier. And from that, I've been successful with getting some buy-in.
Thank you so much. I want to open it up for other questions. Hey, Philip.
Yeah, so thank you again for doing this. It's very, very, very impressive what you've done. I know because I've been in situations where I've tried to get projects like this accomplished. It's not easy. And you've done amazing work. And I like the way you try to put yourself in somebody else's shoes. I'm talking about the administrators and the physicians, and understand that, because I think that's really key to being successful. It's not about what you want to do, it is, but to get there, you have to understand everybody else. I'm wondering, what you think the long-term viability is if we have, I'm thinking mainly financially, how do you propose to ensure the long-term viability of the program financially? Because you're doing a lot and you need the resources. And I'm just wondering what your thoughts are about that.
Yeah. So I am now at a point in my career where I recognize that I cannot sustain anything on the kindness of strangers or grants, right? That is a great way to get started, but that's not sustainable. And so, in each and every one of our processes that we want to implement, we are constantly asking, how can this be sustainable? So, specifically for our healthcare pillar, looking at if I am able to minimize the time that it takes for the physician to be face to face with that person with IDD in front of them by doing a lot of pre-work and like loading it, giving it to others within, like I look at, we have case management. So as opposed to reinventing the wheel, might I retool or retrain our case managers so that they better support this population? So the physicians, when they're face to face, they're working on their task. Right now, I feel like physicians who work in this space are doing everything and they spend a lot of time, and that's not the most, that's not a financially stable approach. And so for that integrated model that we're looking at what are the disciplines that are needed in order to provide the best care for this population in the most economically sustainable way. So once we come up with the model, we've concurrently been having conversations with the payers because you got to have them at the table. And we're saying, well, this is our model, and this is how our models is going to demonstrate that we will decrease obesity, we'll decrease emergency room visits, we'll decrease lengths of stay. That's money. We can then say, gosh, how are you going to reimburse us in order to achieve this? I mean, we do this with other chronic diseases. So this isn't something novel. It's just applying this model that we're currently using to this population in order to improve quality and decrease cost.
Thank you so much. Are there
Thank
other
you.
questions?
There's a question. I'm curious how you have considered addressing needs related to sexual and reproductive health. I love that. So yeah, now that I'm in family medicine, one of the things when I spoke with the family medicine docs at Harbortown, I'm like, what are all the things that you do? Because family medicine is not pediatrics, and I am just amazed at all the procedures and everything they do. And so I've asked them, how do you, whether you're doing, I don't know, a PAP on a patient, how do you do that in someone with IDD or with a physical, and the group I work with, they're very, I feel like they're honest. They may say, well, gosh, not very well, or, it's case by case basis. So again, there is a need. So I don't have the answers. And when I was talking to Dr. McKee earlier, I was saying that I like to see what others are doing and see, might we learn from others and then adapt and replicate that at our site, because I'm not a family medicine. I don't know all of the procedures that they do. I don't have those competencies. But what I do have, I know, is in my approach that I may lend. But we're looking external to see what other folks are doing so that once we finally are able to build a full lifespan approach, that we know whether it's reproductive health, whether it's colonoscopies, whether it's, simply taking vitals, that it's done, so that we can address the needs specifically of this population.
Okay. I actually, I'll throw in another question I have. I'm sure others will be chiming in shortly. I know you mentioned the burden of other medical conditions, chronic medical conditions such as diabetes, hypertension, and so on. I was just curious if you had tailored or modified your screening parameters as a result of that. Could you tell me a bit more about that?
Yeah, so this is work that I'm actively doing now. When I heard, from the physicians that I work with, both in pediatrics and family medicine, it's really not knowing what are those appropriate screening. And it wasn't until I had one of my colleagues in peds spent a day with me, and she was sitting elbow to elbow, and she said, I never would have thought to do a lead screening on an 8-year-old. Why are you doing that? I'm like, well, he mouths. He's, putting non-food objects in his mouth all the time, so he's at risk at lead. We live in Michigan, there's lead everywhere. And she's like, well, we as pediatricians, you routinely screen for lead for the toddlers. But for me, I specifically ask the question at every age about food mouthing behaviors. I specifically ask at every age around safety, eloping, just some basic questions. And so what we started doing was like writing down, you do things just because it's kind of what you do, but we started writing down the things I screen for across pediatrics, and then turning to family medicine. And then I asked the question, how do you screen for depression in a 6-year-old with intellectual disability? How are we screening for health knowledge for that 18-year-old? And the truth is we're not. We don't do it. So I'm in the process of looking at what tools are currently out there that exist that are specifically for this population as we screen across the lifespan. And what additional screeners might we use that, for patients because of their co-occurring, if they're using seizure medications and puts them at risk. If they're using, so we're doing this hopefully through an express lane and EPIC, and we're calling it our IDD express lane. So regardless of the age of the patient, you pull up that express lane that would have a templated note, but also those templated screeners that you should do at the age, depending on, what your history brings forth. Because the idea is not everyone's going to have all this knowledge, but if we leverage technology and a template and a decision tree, my hope is we would get more providers to use these IDD express lanes and provide appropriate care for the patient. That is our work in progress. We're not there yet. We're just in the gathering up. Okay, at the age of 4, what are the things you're doing? And what are the co-occurring diagnoses commonly seen at this age? And what do you want to do? So it's really writing and graphing all this out before we work with our IT people to create an EPIC IDD express lane.
One thing that we have done is actually develop this smart set to provide some guidance for primary care providers. This was with family medicine physicians on some recommendations for people with physical disabilities, but have not done it for IDD. I know Noah was on earlier, and we both kind of are pretty aggressive with a lot of the screenings. So A1C, we often offer DEXA screenings much earlier,
Yes.
Especially if they're on epileptic medications. So there are a number of modifications, and I know a lot of this is really more expert-based just because of limited data overall. A lot of these individuals have been excluded in a lot of the evidence-based work. But I do strongly believe that, that is something we do need to do a better job guiding. And I'm thrilled to hear that you're trying to integrate EPIC. And then the one other thing that might be of interest here, we screen people pretty aggressively on whether they have a disability and what type of disability and what accommodations they require. And I know our department, we push it through portals, new visits, any wellness visits, they get that questionnaire, and it's been adopted very readily. And I know you were mentioning that earlier story, didn't know, and then it took a lot of time. And
yes,
we're trying to avoid this very reactive nature and trying to be proactive in meeting the needs. And we may not be able to meet all of them, but it helps to move forward towards that. And I'm happy to share that.
I would love that. And I actually I'd known you guys had done that work. And like I said, I'm not trying to reinvent the wheel. I'm like, if it's already done, I think that's brilliant, because that is one of the first things. If we can identify the population, right, at scheduling, we could work on scheduling them in a template that works for the provider and the patient. That's half the battle, right? So it's not a double book. It's not a 20-minute follow-up. It's the appropriate schedule. is half the battle. I love that. My question for that, for your disability, Swear, is that then, does everyone within Michigan Medicine see that on their front page, or do you have to go somewhere to identify it?
So it's gone live for everybody. So we have two plus million patients that are within Michigan Medicine, and it is available, and patients can see it. They can go through it to kind of identify it. Some gets pushed. Certain departments do that, some don't. And so unless you're actively seeking it, it may be a little bit harder to find. It is located on the storyboard, so it's available for everybody. But in terms of the pushing, the effort to screen, I would say only a few departments, family medicine being one of them, does that.
Yeah.
Yeah.
I love that. Yeah, I definitely want to learn more. That is like really foundational to some of the work that we're doing, having to identify the patients. I love it.
So one of the things that we were chatting earlier, and I just want to open this up, we're really trying to find ways where we can collaborate and kind of make a more robust network of disability health champions, especially in the clinical space, to help with a lot of the disability health curricula, medical education efforts. We're only 1 hour apart, but this was until recently. I think it was a couple months ago. I think Mary Sparks got all of us involved, and that was the first time we were able to connect. So we're really just trying to figure out how we can kind of work better together, rather than reinventing the wheel. So we can hopefully share some ideas, improve the care for these individuals. And there's a lot of work to be done for this. So I know we're almost at the end of the hour, so I appreciate everybody coming. And if there's any further questions, feel free to reach out to Dr. Johnson-Hooper, and I'm sure you'll hear more in terms of hopefully we'll find some ways where we can expand this partnership.
Absolutely. And I'm just now, I'm going to the chat. I'm going to put in the, so you have it. I just realized I didn't do that. Put in my contact.
Yeah, and we can, hang on 1 second.
I appreciate time. This is absolutely wonderful.
Yeah, thank you so much. Appreciate you joining us.
Absolutely.
Thank you so much.
Absolutely.
Bye.
You guys enjoy the rest of your day.
You too. Bye-bye.
Bye.
Thank you.